Hi, friends, and welcome to the Dr. Green Mom Unfiltered podcast. This is your host, Dr. Ashley Mayer. I feel so honored to have this opportunity to support you and your family on your parenthood journey. Just a note before we begin, if you enjoy this podcast and would like to support my work, please consider subscribing at drgreenmomvip.com. Subscribers have access to my full-length episodes, my very lengthy library of parent-focused resources, including my treatment protocols, access to my parent support group, and exclusive product discounts. As always, I appreciate your support. And now let's begin. And we're live, Dr. Lydia.
Hey.
Yay! Welcome, everybody, to another episode of the Dr. Green Mom Unfiltered podcast.
Yes.
With your host, me, Dr. Mayer, and Dr. Lydia. Her and I are going to have so much fun today with this topic. So, Dr. Lydia, I want you to introduce it because she's pregnant and she's going to have her first babe and she has these questions. And so she's like, hey, Ash, do you think that we can do a podcast all about this? Because she wants to know too.
Yes, this is for selfish reasons, but also because we get a lot of questions about this in the VIP group. So shout out to all the moms who are just stressed out right alongside me. I really want to talk about vaccine decision-making because it's a tough one and it feels like the stakes are high. It feels like if I make the wrong decision, is something going to happen to my baby? And that's just very stressful for all of us. And I do know that we have this wonderful vaccine strategy guide and it outlines the different diseases. So I thought today, let's discuss what are we actually vaccinating against? What do I need to worry about? How do I figure out case counts? Is this a disease even relevant for me? Is this something my baby can catch? And if so, what's going to happen to them if I choose not to vaccinate? So that's what I want to dive into today.
Everything.
You, the expert.
I want to know everything about vaccines.
Tell me everything and tell me how to make a decision.
To make a decision. So as a caveat to all of this, I want to give a shout out to all of those parents who are in a mandated state. And this is a great episode for you all to listen to. It'll just be more difficult for you to be able to make some of these decisions based off of risk factors because for your kid to go to school, they have to be fully vaccinated according to the CDC. And so there are ways to lessen the amount of vaccines if you choose. For school, it's just doing it in a savvy way. So I just want to commend you parents who are living in a mandated state. And that currently is New York, Maine, Connecticut, West Virginia, and California. Okay. So right before we started recording, I told Dr. Lydia that I wanted to speak to some of the top questions that I get, because this is going to lead us into discussing what we're going to today. I get this question. I was doing, I don't know, I think Dr. Lydia, 40 plus consults a week for vaccines with parents a couple of years ago. It was a lot. It was a lot of questions. And the number one question was, all right, doctor, the reason why we're on here today is I don't really care about all the fluff. I just want to know which ones I have to get and which ones do you recommend everybody across the board get all the time, no matter what? Like which ones are most important that I absolutely have to get? And I want to answer that because I don't think that any of them are necessary for everybody all the time. So sorry to burst your bubble, but I don't have a template. I don't have a, hey, you've got to absolutely do these three, because the way I assess whether or not you should or should not vaccinate your kiddo, number one is based off of risk of the disease. What is the current risk of disease? And that changes all the time. And so for me to give you a blanket statement of which vaccine I think is most important and you have to get all the time, I don't have one. And that leads into, what do I do for my own kids? Well, one of the ways that I assess risk factors for your family is how likely or how comfortable will you feel as a parent to care for your child who has one of these diseases? So you can't really ask me what would I do versus what you would do, because I am a doctor, and so I'm in the medical field. I'll probably feel way more comfortable with some of these symptoms and diseases than you might be as a parent. So it doesn't really matter what my choice is on whether I vaccinate or not, you know? And I think for you too, Dr. Lydia, you're going to be a new mom, but you also feel quite comfortable to a certain level caring for people in general who have, difficult diagnoses. So Dr. Lydia and I are kind of in the same boat with that regard. And the last one, and this is how we're going to get into the meat of this podcast, is everybody wants to know this. Every time I put out a vaccine video on social media, I get this question in the comments. And it's, what do you say to someone, though, doctor, who says these diseases aren't around anymore because of vaccines? I'm not trying to say whether or not these diseases were around prior to vaccines, and if vaccines were the ultimate end all be all to reduce disease, doesn't matter to me. I don't actually care what the answer to that question is, because my job as a doctor, when I'm talking to a patient, is not to discuss, what happened for these diseases to not be present in the environment as they used to be. My job as a doctor is to sit down with you and decide, hey, what are we doing for your kid today? Not last year, not 20 years ago, not 50 years ago. It's, what is the current risk for your child? Because we know that with disease comes potential side effects, severe potential side effects and symptoms. And with the vaccine, potentially is severe side effects, severe symptoms. So it doesn't matter. So asking that question makes no sense to me, because it's not pertinent to me. Does that make sense, Dr. Lydia?
It does. And I can tell sometimes in our VIP group when moms ask questions, they're getting caught in the weeds in terms of a larger vaccine discussion about what is right and wrong, like from a public health or just sort of on this big grandiose scale, when all they need to do is focus on their family and the decisions that are right for their child and their unit, and everything will flow from there. It's just too difficult to make some grandiose decision, taking in all these different data points. Like, it's hard enough to just focus on your own family and what's right for you. Is that right?
Yeah, our job as doctors are to give you informed consent for today, for right now. And you know what? Say, 80% of the population one day decides to stop vaccinating, which just is not going to happen. But if that were the case, then all right, let's assess, 10 years from now or 20 years from now, let's assess what to do for your child then. Okay? That'll be your grandkids and your great grandkids. Like, my job is just to help you reduce the risk for your child, whatever that looks like, risk of disease or risk of vaccine injury.
With the information we have at this time.
Yeah. So I think the reality is, and I love what you said about getting in the weeds. People who want to argue with you are trying to put you in the weeds to begin with. So just stay out of them. Just ignore the question. You don't have to respond. And if they do ask you, just say, what's the point? Why? Why are you asking? Like, who cares? I don't care. And you know what? Why are you asking? I don't even care about your answer. You can be nice about it. I've gotten to the point in my age, ripe old 45, I'm getting to be kind of blunt in my ears. All right. So this is what we're going to do. We're going to run down each of the diseases on the vaccine schedule. Oh my God, is this going to be dry or what? And we're going to talk about the most important factor in deciding whether you should vaccinate your kid or not. And that's current risk. What is the risk that my child's even going to ever contract this disease? Right? Yeah. So do you want to start it off, Dr. Lydia? How about you talk about what the disease is, and then I'll get into talking about the nitty gritty on the cases, the current cases.
Yeah. Okay, let's do that. And the reason that we're breaking it down by disease is not to take you to immunology class or do something completely long-winded. It's because you do have to think about the vaccines on an individual basis. Like, I'm sure for some maybe philosophical reason, you could lump them all together and say yay or nay. But really, I think we encourage parents to pick apart, like the vaccine strategy guide is broken down by disease for a reason. And it's because you want to be making these individualized decisions. And that will build your confidence too, because you're going to feel like, no, I'm making a decision about hepatitis B because of XYZ. So, yeah.
And nothing makes a pediatrician's internal heart smile more, even if you are arguing with them, than knowing what you're talking about. So if you can go in and you tell your doctor, hey, we're not doing hepatitis B and here's the reasons why, or we are doing hepatitis B and here's the reasons why, they can't argue with you. If you have sound evidence, their internal heart will smile that you actually are educated. They may outwardly not show that to you, but it's important to know each of these diseases. And then I'll give my spiel on what the current case count is. And hopefully by the end of this podcast, you'll have a really, really great understanding of, hey, do I want to do this one? Or do I want to hold off? Or do I want to not do it at all? So I hope that's what we get out of this, right? All right.
Okay.
So
let's dive in. We were going to discuss hepatitis first. And hepatitis is an interesting one because it's really a disease that impacts adults. It's not so much a high risk. We're going to talk hepatitis B first. It's less of an issue for kids unless the mother is positive for hepatitis B. And the disease can range from pretty asymptomatic in children, but they will end up being a hepatitis B carrier, which could potentially cause liver inflammation later on. There's, a possibility of that. But 90% of infants that are infected at birth will go on to develop chronic hepatitis B. However, this isn't going to be a surprise to mothers because you would be tested. You would know if you have hepatitis B.
correct. So during pregnancy, we test all mamas for a whole panel of diseases, and one of them is hepatitis B.
So knowing that it's a disease mainly in adults, how do you feel about it, Dr. Mayer, in terms of children receiving the hepatitis B vaccine?
I tell parents this: if you are hepatitis B positive and you are the mama, definitely get your kiddo the hepatitis B shot, all right, at birth. Or you don't have to wait at birth, but maybe second month. At birth is fine. That's when the CDC actually does it or recommends it, is at birth. Some doctors like to wait to the 1 or 2 month appointment. If you have a caregiver who is also hepatitis B positive, say it is a father or someone who lives in the home, that may increase your likelihood of wanting to get this vaccine. Now, Dr. Lydia has posted here current cases of hepatitis B, and I don't typically talk to parents about current case count of hepatitis B, and here's the reason why. You don't get hepatitis B from coughing on somebody, and it's literally blood-borne. So you're not going to, if you see the case count in Colorado, say there's 6 cases in Colorado right now, it doesn't matter because standing next to somebody with hepatitis B is not going to give you hepatitis B. Does that make sense?
Yes. So it's transmitted primarily through blood, bodily fluids of various types. So it's not easy for your baby to just catch hepatitis B on the subway or something like that. It's not going to happen.
Yes, correct. And so case count is kind of a moot point to me for hepatitis B. It is one of the vaccines that we start. It is the only one actually that we have on the schedule that we start at birth. And I completely forego this. So I'll recommend to parents, hey, look, if this is important to you starting in school age, if you want to start the schedule in school age, great. This is a vaccine that does come with potential side effects. Well, they all do, but this one is a aluminum-based vaccine with a good amount of aluminum that early in childhood and infancy. To me, it's not necessary. Again, none of this is medical advice. This is just my personal opinions and Dr. Lydia's personal opinions. So don't take this as, the end all be all. But I think that's what we got for hepatitis B. So
yeah. It's really a vaccine that's designed to protect adult populations, isn't it? Like thinking that this hepatitis B will carry through because there's some high risk populations, intravenous drug users and such, not to label people if you have hepatitis B. There's a variety of ways of getting it. But that's really the point of this vaccine.
And the reality is, over time, titers will wane. So that means waning means titers will go down and you won't have as much protection to the vaccine as you once did. So by age 11 to 15, when, I don't want to say this, someone's likely to be promiscuous at this point, their titer protection may have waned enough to where they'd have to get reinoculated. So right about the time that you might need tighter protection, you're not going to have it anymore because you got the vaccine in such infancy when the immune system was still trying to be primed. So this is one that I typically push off to later, unless, as we just discussed, the risk factor of someone in the home who is hepatitis B positive.
Now, when we pop over to hepatitis A, which is also a viral infection of the liver, and it's very mild in children, usually they're asymptomatic and they just end up kind of carrying it and probably infecting other people, adults. But this was something that came up in our VIP group because somebody was traveling to an area. And I think it's important that we discuss that, because if you're sticking close to home, it is different than if you have family that you're visiting abroad in an area where hepatitis A can exist. And this is a fecal oral route, so it's like contaminated water and food and such.
Yep. And so that is the main component. That's the main risk factor. So if I have patients who are traveling abroad and they're going to a region where hepatitis A is highly endemic, I'm just going to read it to you. Currently, it includes South Asia, particularly Bangladesh, India, Nepal, and Pakistan, the Sub-Saharan and North Africa, parts of the Far East, except for Japan, South and Central America, and the Middle East. If you're going to those places, yeah, I'll recommend you get the Hep A. The last thing that you want to have to deal with on vacation is severe bouts of diarrhea. Although I will tell you, there are many other ways to get severe bouts of diarrhea in these countries. It's not just hepatitis A. So I always say bring prophylactic antibiotics as well. But other than that, do I typically recommend the hepatitis A vaccine? No, I actually don't. And again, this is up to you. It's not that parents are going to say, oh, Dr. Mary, you don't recommend it, I'm not going to do it. So some of them will say, oh, well, you don't recommend it? Well, I'm still going to do it.
And a lot of it may be your travel plans, so you can have that peace of mind.
Yeah, which is fine too. Again, if you live in a mandated state, unfortunately, hepatitis A is necessary to be able to go to school. Here's a good one. So, Dr. Lydia, let's chat Haemophilus influenzae type B, HIB.
Yeah, which is actually a bacteria, not a flu virus. Very misleading name.
A lot of people say H flu. They're like, oh, the H flu is going around. The H influenzae is going around. It is not a virus, it is a bacteria.
And we're specifically talking about type B, because I think there's like A to F and maybe some other alphabetical letters in there too.
Yes. So there's A to F, and B is the only one we vaccinate for, people. Okay? There are other potentially invasive strains. I'll talk about that in a minute. But HIB, type B, is the only one we vaccinate for. And if you get vaccinated for type B, it does not protect you from the other strains A through F.
That's good to know.
Yes. So what are the severe outcomes? What happens with HIB, Dr. Lydia?
Well, yeah, mostly it's just a cold, but I think
HIB,
yes.
meningitis, epiglottitis, pneumonia, sepsis, and bone and joint infections. And so what happens with HIB is Haemophilus influenzae, the other strains, typically do not invade the mucosal barrier. They do not get behind the mucosal barrier and get into the blood. That is the problem with type B, is that it is invasive, and then it likes to get under the skin, literally. It gets through the mucosa. And that's how it reaches such havoc. And this is one of the meningitis diseases that parents are terrified about. So pneumococcal is another one. But Haemophilus influenzae type B, meningitis, is a serious concern. And the symptoms, I guess, aren't really too important. We've just spoken about the major concerns that happen. But sudden fever, stiff neck, vomiting, difficulty breathing, lethargy, and unresponsiveness. These sound terrifying. And when I laugh, someone made a comment that I'm laughing during something serious. It's an uncomfortable laugh. I'm not laughing at the fact that people get these diseases. It's an uncomfortable laugh that this is what parents are actually having to think about. Like, these are serious, serious symptoms that parents have to think about. And so, I laugh it off in a uncomfortable way. How's that? Okay. So how do you get it, Lydia? How do you get HIB?
So this is one different than the hepatitis, which is like fecal oral route or serious, like blood-borne illness. This is respiratory droplets. So this would be easier to get, I would say, through coughing and sneezing and close contact.
For sure. Now, here's the thing with HIB is that there are several other strains that are becoming invasive, or they have been invasive, but we don't vaccinate for them. So when your doctor calls and says your child has an ear infection and it is due to Hib, they actually don't mean Hib. They mean a non-typable strain of Haemophilus influenzae. So I've had to make mention to this multiple times because so many parents, if I talk about HIB and the case count, because I'll tell you the current case count is a couple cases this year in the entire United States. When I talk about it, parents are like, there's no way that my child was that one single case this year. It's like, you know what? You're right. Your child was not that one single case this year because your child didn't actually have Hib. They didn't have HIB type B. They had another Haemophilus influenzae strain, which most notably will cause ear infections. So let's take a look at the current case count, and this is how I assess the importance of whether you should get this vaccine like today or not. The current case count in the United States right now for week 17, so this is through April 26th, 2025, for children under age 5, there's one single case in all of the United States this week, and that happens to be in Ohio, my home state. So if you live in Ohio, does that make you feel uncomfortable enough to want to vaccinate your child for Hib? And this is a question for you. Many parents will react differently. So one parent might say, yeah, I definitely want to vaccinate my kid because there was a case here in Ohio. And other parents may say, no, that's not enough for me. So you have to decide what is your own personal limit of concern. And that's how I help parents to assess this. Now, there have been 6 cases to date here in the United States all year. And so if that number bothers you, you can start the vaccine schedule for your kid. I will say this is one of those diseases that we vaccinate for where the longer that you wait to start the series, the less doses that they need. So it's a 4-dose series, and the longer that you wait to start, the less doses they need. So if you wait until between the ages of 12 and 15 months to get this vaccine, they only need one single dose.
So that might be a strategy for some of our parents in mandated states. They could.
Well, the great thing about that is that Hib and pneumococcal, so the HIB vaccine's not even on the CDC list for mandated states to enter school because by age 59 months, by age 5, if you have not vaccinated your child with HIB in a mandated state or in any state, you will never have to get this vaccine. So it falls off the schedule completely by age 5 if you've never vaccinated your kid for it. So your child actually does not need Hib to go to school starting in kindergarten or first grade. I actually think kindergarten, I'll have to take a look. Some states, Hib is required for 1 dose of Hib is required for kindergarten. In some states, 0 doses are required. But if they do daycare in a mandated state, it is required that they get the HIB vaccine. Okay? So that's the current case count. Currently, I live here in Arizona, and I would tell a patient, hey, look, you're hunkering down here in Cave Creek, Arizona for the next several months, and you don't plan to go anywhere. You're going to be hanging out with your babe, and you might have some visitors on occasion, especially if it's in the summer months. Postpone this. And most parents will concur. Some of them still want to do it, and that's okay. But I am simply giving you what the current risk is and helping you to make a decision that, there's not a large amount of cases. There's 6 this year here in the United States.
It's so helpful to know those numbers because if you just read about the meningitis and the epiglottitis and sort of the scarier things, you need to balance that information with, well, how likely is it that this is even going to be in my child's universe?
Exactly. And, some parents don't want to have to worry about it. And if you're that worry wart that takes your child to the mall and you're absolutely terrified to be there because you haven't vaccinated your kid yet, you might want to think about going to vaccinate your kid. Okay. So this is one thing I just want to reiterate is that we actually can probably thank routine vaccination for the decrease in Hib over time, over the years. But I'll also say that other strains of Haemophilus influenzae have become more invasive now that we vaccinate for Hib. So we have opportunistic viruses and bacteria, and they will change their ugly shells. They will start to mutate. And so something just to keep in mind, that you can come down with invasive Haemophilus influenzae even if you're vaccinated. It just may not be type B. And now they're seeing more and more of invasive H influenza that we don't vaccinate for. So it's just something to keep in mind. All right, so moving on down the line.
Next up, we have polio. And this is one where you probably get that question, is polio even an issue anymore? Do we need to vaccinate against this? So I could see that question coming up. Polio used to be around quite a bit, I think up until maybe about the 1950s, I think. And it can cause irreversible muscle weakness and nervous system damage. So it was, we think about the iron lung and those sorts of things. Although for most people, it was a fairly mild infection. It's a fecal oral route. So primarily in areas of poor sanitation, I would say you would get it nowadays. So what are your thoughts on polio?
I did a really great reel video on Instagram that went viral several weeks ago, and I discussed polio, and I just wanted to let you all know about the current case count. And just as a caveat, less than 1% of those who contract polio will go on to symptoms of paralytic polio. So for most, you won't even know that you have polio. And that's how it can spread so quickly, is because you don't know that you have it. And so less than 1% of all cases of polio will be paralytic. So I posted the current paralytic polio case count, the wild polio cases. I think there was 6 at the time. It was probably 6 weeks ago that I did this. There were 6 cases in the entire world of wild polio, and it was in Afghanistan and Pakistan, which are the 2 countries that are typically always endemic to polio, and that's the only 2 places where we've seen wild polio for a while. Now, the vaccine-derived paralytic polio, I want to say there was about 15 cases. Don't quote me on this. It was several weeks ago. There were about 15 cases in the world of vaccine-derived paralytic polio, and that was also overseas, endemic around the areas of Afghanistan and Pakistan. And what we'd like to talk about, if we're all about talking about vaccines and how important it is to vaccinate your kids, is what we hear a lot about. It's because there was a polio case, a vaccine-derived paralytic polio case in New York a couple years ago. And most people don't know it was vaccine-derived. So I want to make that statement, is that there's more cases of vaccine-derived polio in the world currently than there are wild polio cases. And that is a discussion for another podcast episode. But currently, to assess current risk here in the United States, I've got a 2-month-old. I'm hunkering down here in Cave Creek, Arizona. I might fly to North Carolina this summer for a week. Should I get the polio vaccine? Well, I just told you what the risk is. If that makes you nervous, that there's 20 cases in the entire world and they're not anywhere near the United States, if that bothers you, start the vaccine process for your kiddo. This is one of the vaccines on the schedule where you can get a less dose in the series. So if the 3rd dose of polio is after age 4 and 6 months after the 2nd dose, then you can get away with 3 doses instead of 4. So if you live in a mandated state, this is one of those vaccines where just wait to get that 3rd dose after age 4, and you will have completed the schedule fully for a mandated state. And I don't like to say this, but the most vulnerable populations who are at risk for disease are in the first year of life, most specifically the first 6 months. Also, the most vulnerable to vaccine injury are in the first year of life, most notably the first 6 months. So if you can delay this, why not? Because if there's no risk to you as a parent, if you feel like there's no risk, then this is one of those that you can delay. And if you choose not to, that's fine too.
Can you speak to the difference between the oral polio vaccine and the injectable one? Like, do parents in the US need to be nervous about vaccine shedding at home?
Such a great question. Absolutely. The IPV vaccine, the inactivated polio vaccine, is what we give here in the United States. We do not give the live virus oral polio vaccine here in the United States. So I'm so glad you mentioned this. I don't want parents thinking that, oh my gosh, if I give my kid the polio vaccine, they can shed it and give it to someone else. That's absolutely not the case. The oral polio vaccine is overseas. So it's given overseas for a few reasons. It's another podcast. But for here in the United States, it's the inactivated polio virus is what we give here in the United States. And no, that does not shed. That does not cause polio or paralytic polio in another individual. I'm so glad you mentioned that. I don't want to fear parents at all.
Yeah. So you're okay if you're summer traveling to North Carolina. There's not going to be vaccine-derived polio floating around.
Unless they came in from another country like that person did in New York and contracted the vaccine-derived polio. And that was one case. And I will say I love public health, where I did a couple of years ago. It got squashed very quickly. Squashed meaning quarantine happened with everyone who was involved, and it was really great. I can't say the same now. I don't know what's going on with public health at the moment right now for a multitude of reasons. And one of them being I can't find current case count without having to be a private investigator here on the CDC website. They've completely changed it since 2024. So in 2025, I asked Dr. Lydia to grab the links for the current case count on the CDC website. And she's like, you need like a PhD to find it, right? It's nightmare. So since now here in 2025, it's been really, really difficult to find the current case count. It's there. It's just really hard to find. And they were updating it weekly. And now I think they're updating it twice a month. So what used to be weekly now here in 2025 has all of a sudden, cut itself in half. So it's now twice a month instead of 4 times a month that they update it. Anything else on polio?
I think that covers it.
I think that was gooder.
Yeah. Okay, let's talk about chickenpox. Varicella. So I just got chickenpox as a kid. Did you get chickenpox as well? Like, I was not vaccinated.
I sure did, from Caroline Anthony. I was in 5th grade. Yes, I did. And I'm here today to talk about it.
Right. Okay. We made it through somehow. Yeah, I just stayed home. I think it was in kindergarten. I just stayed home and had popsicles.
Me too.
Most kids will recover from chickenpox in 1 to 2 weeks. It has sort of the characteristic itchy blisters. And it's airborne spread, so it spreads pretty easily, coughing and sneezing and direct contact. So one person can infect 85 to 90% of close contacts who are not immune. So this is probably mostly a concern for maybe people who've never had, it used to be in the past, it was mainly a concern for people who'd never had varicella and they were getting it as an adult. Varicella is also the same virus that causes shingles later on.
Yes.
So we vaccinate against this now, apparently. This is a thing. How do you feel about it?
We are doing this now. So it's one of those that the most vulnerable populations can't be vaccinated for it anyway. So you don't actually get the varicella vaccine until after your first year of life. And that's when the child's most vulnerable. So most specifically in the first 3 months of life. And then women who are pregnant. So I typically recommend to parents, if they have not received the chickenpox vaccine prior to going to college, it might be something to talk to your child about, whether they want to get that vaccine or not. And the reality is this, like you just said, the older you are, the worse this virus is. So the more insult to injury, the more issues, the more concerns, potential hospitalizations, the older you are. If you get chickenpox, my husband had chickenpox in high school. Oh my gosh, his story is hilarious. His parents still made him go to school. But it was dreadful for him. Like, it was absolutely dreadful for him. And so I tell parents, if this is something that you want to delay, talk to your child about it before they go to college. Now, you did mention shingles.
Yes.
So I want to speak to that real quick, because before we started vaccinating for chickenpox, the chickenpox virus was ubiquitous in the environment. It was everywhere. So our immune systems, Dr. Lydia and I, who had chickenpox at a young age, we always received in the environment, our immune system received these potentized doses of immunity to chickenpox because it was everywhere in the environment. Now with the vaccine, chickenpox is not in the environment to give our immune systems these potentized doses of immunity. And so now, because chickenpox is, so we see the commercial, shingles is the chickenpox virus living inside you. We don't see these potentized doses of immunity. And so we have these weakened immune systems to varicella, and we're seeing a really big spike in shingles. So now as an adult, we're seeing so much shingles. And the idea is that we're not receiving the immunity that we used to in the environment, these potentized doses of this virus. And so lo and behold, just in the last few years, right after the chickenpox vaccine was released, within 10 years, the shingles vaccine got released. So it's now we got to protect you from shingles because your body can't do it naturally anymore. So I just wanted to speak to that. That has absolutely nothing to do with our podcast today. How do I get off on tangents like this? I think we're just talking vaccines.
No, it's good to know. And if you get the varicella vaccine as a child, you will still need a shingles vaccine later on in life. Is that correct?
Yeah, typically.
It's not that you have immunity for the rest of your life.
Well, you don't need it if you want it. Yeah, my husband asks me all the time. He's like, I'm so afraid of shingles. What do I do? Well, I've been getting shingles since age 12. So I'm like, honey, I don't know what to tell you. You make that informed decision. Why don't you read the package insert for shingles and then you decide what you think is best for your adult self.
She's all about informed consent. She doesn't even tell her own husband what to do.
No, correct.
Not taking on that responsibility. You make that decision yourself, honey. I like that.
Yes. So, yes, ode to my poor husband. So that's what I have to say about chickenpox. Let's look at the case count. I know that's really helpful for some. All right, so the current case count here in the United States is 40 cases this week. Most of the cases are coming from East North Central area, which is Ohio. Ohio, Wisconsin, Florida, Colorado. Those are the states where we're currently seeing some chickenpox cases. It's actually year to date, we have half the cases this year that we had last year. So last year, this time we had 3,000 cases. And this year, this time of year, we have 1,500 cases. So it waxes and wanes. It's cyclical. So some years we have a lot of cases and some years we don't. So what does that remind you of, Dr. Lydia? I'll tell you, measles. So the measles case counts vary every year. They go up and they go down. Why is the news outlets not talking about varicella? The case counts go up and down. It's just not talked about. I feel like it's generational. I feel like so many of the people now, like who are in their 40s and 50s, all got chickenpox. And so it wasn't a big deal. So we don't talk about it. But the generation of those who all got measles, they're now dying off. So there's not many people to look at it and be like, yeah, but it was just measles. And it's not. I don't want to make less of measles and varicella because there are vulnerable populations where it's just awful. But I do want to say that measles and varicella are cyclical. So I want to make a point to say that. Do you got anything else, Dr. Lydia?
Yeah, wow, 40 cases this week. That seems like, I feel like when we were kids, it was like 40 cases a minute, 40 cases in my school.
Well, I'll say that after that slumber party I had that night, 40 kids probably had chickenpox. So
Chickenpox just in the goodie bag that you bring home after the birthday party.
I want to thank that friend of mine for giving me chickenpox so that I don't have to worry about it now. I don't have to worry about having to go get the vaccine because I hadn't had it. So thank you, Caroline, wherever you are, for giving me chickenpox.
The gift that keeps on giving. Love that.
Which disease is up next, Dr. Lydia?
Pneumococcal, which is Strep pneumoniae. It's a bacterium. And I kind of think of this one a little bit like Hib in that it can do the meningitis, get into the bloodstream, kind of penetrate into the system. And there's also a lot of different strains. So, do you want to speak to that?
Yeah, so it is like Haemophilus influenzae. It is a bacteria. The invasive strains, just like Haemophilus influenzae, will get through the mucosal layer and wreak havoc on the blood system. And this is another one of those meningitis diseases. Now, there are several strains that they have found to be invasive. So I'll say that in 2000, the year 2000, the vaccine that came out was Prevnar 7. And that had 7 invasive strains that we vaccinated for. There's like over 100 strains. There's a ton. Don't quote me on that, but there's tons and tons and tons of strains. Most of them aren't invasive, and then your kid will get an ear infection or runny nose or fever or cough. But the 7 that we vaccinated for, that was in 2000. We came out with Prevnar 7. And Prevnar 13, so we added several strains to the vaccine and named it Prevnar 13, and that was in 2010. And it was because, just like Haemophilus influenzae, they saw that after introducing this vaccine, there were other invasive strains, opportunistic strains, that decided to come out and play. And so then the Prevnar 13 was introduced. Now, the Prevnar 13 is most notably what I remember, because for the past 15 years, that's what we've been using. Now, just in 2023, the Prevnar 20 vaccine came to market, and now that's 20 strains, quote unquote, invasive strains that we now vaccinate for. So we continue to add strains to this vaccine. What I find most interesting, and not necessarily part of this podcast, but I definitely wanted to say it, is that the Prevnar 20 is actually less immunogenic or less effective than the Prevnar 13, but it has broader protection. So it's quote unquote protection. I'm using air quotes, protection. It's hopefully protective to those 13 strains. But every time we add more strains, it makes these strains that we've got in there less potent to be protective. Does that make sense?
Yes.
And so, as an aside, the Prevnar 13 is actually less potent than the Prevnar 7 for immunogenicity. So it's less effective than even the Prevnar 7. So now we have the 7, the 13, and the 20. And the 20 is the least effective, but it's broader. So it may help protect against some of the ones that weren't in the previous vaccine. So I wanted to just say that. But who are the kiddos that are most vulnerable, Lydia?
Looking at kids under the age of 2.
Mm-hmm. And that's across the board. So we've got the little ones are the ones we want to protect against for these diseases. And so the most vulnerable population is under age 1 for sure, for the disease or to get the vaccine. Now, the Prevnar vaccine is also another one where the later that you start the series, the less doses that they need. And if by school age they haven't received this vaccine, they will never get it. So this is another one that the older the kiddo gets, the greater their immune system is working. And it's super robust by age 5, even without this vaccine. And if your kiddo sees strep pneumonia, which is pneumococcal in the environment, their immune system should be good to take care of it. So we do not vaccinate after school age for the pneumococcal vaccine either. So in a mandated state, this is not a requirement to start first grade, this vaccine.
That's fantastic information.
But if you wait until after age 15 months, I think, or age 2, to get the first dose, they only need 1 dose in the series. So that's helpful. Yeah, and same thing, right, Lydia? This is all respiratory droplets.
Yes. In the nose and the throat.
Easy to pass on to somebody else. So this is one of those where, again, we want to assess risk, right? We want to check to see
always
how many cases are in the United States right now. And I just pulled it up. So here in the United States, when it comes to pneumococcal, so if you're wondering, should I get the Prevnar 20 for my child? This week in the United States, there are 3 cases. So I'll tell you, Ohio, good old Ohio. If you want a reservoir for apparently vaccine-preventable diseases, go to Ohio. Which is where I'm from, so I'm mocking it. I'm going to make fun of it. I'm getting ready to go back there in July. I might be pregnant. We're not sure yet. But I am going back to Ohio.
God bless Ohio.
Yeah. There's a case in Maryland and then one in Arizona. So Arizona's another reservoir. Why do I end up in the reservoirs?
You're doing good work.
So if you live in one of those states and that stresses you out or that bothers you, then get your kiddo a round of Prevnar.
This one seems like it's probably quite seasonal because there's 239 cases year to date, and we've got 3 in this past week. So would that say to you that it's more of a winter,
Yes,
as many of our respiratory infections are?
absolutely. Yeah, it's really interesting though. Pertussis is more of a summer,
Yeah.
at least this past year, for sure. So I'm glad you mentioned that. It's really good to plan your pregnancies. If you don't want to vaccinate your kid, or if you want to do less doses in a series, or you want to delay the schedule, plan your pregnancy around, make sure that your delivery is typically in the summer, because most of these diseases are not around in the summer months here in the United States. So that's another added bonus to this podcast, is plan your pregnancy.
September, October, November. Those are your primetime months.
Yes. So year to date, so far this year in the United States, there have been 239 cases of invasive pneumococcal. And last year, this time, there were 336. So we have 100 less cases this year. Again, it goes up and down. Some years we have more cases and some years we don't. So keep that in mind. And it typically has nothing to do with vaccine status. Oh, those, we've got more people vaccinating this year, so we have less cases of pneumococcal and less cases of varicella. That's not it. It's just that these diseases they're cyclical. So if that stresses you out, the current case count is 3 cases. If you have a 2-month-old and you're hunkering down in Cave Creek, Arizona, what do? It's up to you. But this is the greatest way to assess whether or not your child needs this vaccine, like right now, or the greatest way I've found. I'm sure, other doctors might have different opinions. You all can have them. I've been doing so many of these vaccine consults that we found the best way is to just look at, what's the reality if your kid's even going to catch this or not?
Yeah, look at the numbers. Yeah, it's a good way to communicate with a physician if you're going into your doctor's office and you're a little nervous to have the vaccine discussion, which is totally natural and normal. Many of our parents feel kind of judged or like they're going against the grain, to come in with some statistics. I will say this one, we're looking in the CDC stacks. That's where we find this information. And what I specifically had to look up was invasive pneumococcal disease and under age 5. So this one was not the easiest to find. Some are easier than others, but it's the invasive pneumococcal disease under age 5. Dr. Mayer taught me how to do that. Thank you very much.
Yes. Haemophilus influenzae is tough too, because you have to look for type B in stacks. So in the show notes, I'll say it right now. I should have said it at the beginning of the hour. We are going to put the link in the show notes on how to access the CDC website to be able to check case count. It is incredibly difficult to do this now, as of 2025. I have a recorded live call in my VIP membership on how to do it. So step by step how to do it if you are interested. If you are confused and you need help on understanding where to access the case count, I have that live call recorded in my VIP membership. Okay? All right, Dr. Lydia, let's chat rotavirus. Let's chat diarrhea.
Yeah, good old diarrhea.
Lots of diarrhea.
So fecal oral route. So usually your little one is at daycare perhaps or at their church group or something, and it's on the toys. It's on little kids touching things and being in close contact. and you've got a lot of watery diarrhea. You can have vomiting. There could be a little mild fever. What you're looking at here is dehydration. So this is also one of those to consider. Do you feel comfortable managing a child with diarrhea? And
Sure.
we at Dr. Green Mom have many resources and blogs to help parents so they're not so scared of this. But it's very common, rotavirus, I would say. Do you think like pretty much every kid in daycare is going to end up with rotavirus sooner or later if they don't?
Yes, by age
Yeah,
1, we don't even
yeah,
vaccinate for this.
because it's so common.
Yep. If your child does not get vaccinated by age 1 for rotavirus, they will never in their entire life be asked to get vaccinated for rotavirus again. It is that common. It is a oral live virus vaccine. It does shed up to 11 days or longer in your child's stool. So picture, I call it a daycare disease. Picture you drop your kid off at daycare. I'm sorry, parents, but kids have their hands in their pants, like they have their hands in their diapers, and they're playing with the toys, like Dr. Lydia stated. And you have a few caregivers who are changing diapers all day. And as meticulous as they want to be to clean, the reality is if your kid's in daycare, they're going to get rotavirus, whether you vaccinate or not. So I say that, whether they vaccinate or not. If you do vaccinate, it is a potentized small dose of rotavirus. Chances are incredibly likely, like 70%, they're going to get diarrhea from this vaccine, which is rotavirus. Your child is going to show symptoms of rotavirus by getting this vaccine. And so keep that in mind. Rotavirus is everywhere. And if you live in a mandated state, this is not necessary to go to school. Just keep that in mind. And do I recommend this vaccine to my parents? No, typically not. That's just my 2 cents. Again, not medical advice, but no pun or pun. Anything else to say about rotavirus?
I was just going to say that this one's really difficult to know case counts because most parents are just going to manage this at home with diarrhea management. And even if you end up, God forbid, at the hospital and you're really concerned about dehydration, oftentimes they will still just manage the diarrhea and not necessarily run a stool test. So just one of those.
Exactly. So what you're going to do is look out for dehydration symptoms. So especially in an infant, you want to see that fontanelle. If it's sunken in, that is, and they're not peeing, they're not wetting their diapers. They might be pooping a whole lot, but make sure they're peeing and they're getting plenty of fluids. And that's why we go to the hospital. So if your child is dehydrated, do not hesitate to go to the hospital because it can be difficult to try to keep up with hydration in your infant if you're just constantly trying to breastfeed them or formula, either way. We don't offer water to very tiny infants, and so they may need fluids in the hospital. So that's rotavirus. Should we chat RSV? I was thinking that we chat RSV like an entire podcast. Because the RSV vaccine is not on the childhood schedule. So it is not necessary to go to school. It's kind of like the flu vaccine choice. So parents have the choice to do RSV in pregnancy. They can do RSV at birth, the antibodies at birth. Those are the options that you have. But in a mandated state, you do not have to have the RSV vaccine.
Okay, we can circle back maybe in more seasonal time as well.
And we have tons of resources at drgreenmom.com. So if you go under the resource tab, you can download our entire RSV vaccine guide, and it's currently free right now. It's also inside your VIP membership. If you're a Dr. Green Mom VIP member, we have it there. And if you've purchased the vaccine strategy guide, it's also there too. So this next few that we're going to talk about are in one vaccine. So it's the DTaP vaccine. So we'll quickly chat diphtheria. Dr. Lydia?
Yeah, it's another one similar to polio where I'm sure you get the question, do people need to worry about diphtheria anymore?
Not here in the United States, but it is in many other countries. We just don't see it here.
So this one was known for sort of creating a thick membrane at the back of the throat that can cause breathing obstructions, but I don't think there's been a confirmed case. I'm in my data here I have since 1997. Correct. So unless you're doing some international travel, I don't know that you have to be also concerned about this one.
Yeah, so the reality is diphtheria tetanus and pertussis are in one vaccine. So if you want to vaccinate for pertussis, you have to do diphtheria. You don't have a choice. So even if you're like, hey, you know, the case count seems pretty low since 1997, there's not been a single case in the United States. However, if I want to get vaccinated for pertussis, I have to get the diphtheria portion of the vaccine. So just to say, it's not here in the United States, but if you want the pertussis vaccine, you got to get it. And I'll say after 3 doses, you're fully protected. After 3 doses of the DTaP, you're fully protected from diphtheria. You still have to get 5 doses, though, if you want to protect yourself from pertussis. So you're fully protected after 3 doses of diphtheria. I think that's all I got to say about diphtheria.
Okay, we can move to tetanus.
Oh, tetanus.
Tetanus is caused by tetanus, the disease state that you think of, the locked jaw, the like stiffness of the muscles and such, is caused by a toxin from Clostridium tetani, bacteria found in soil, dust, and manure, which don't seem like that would be so high risk for a little baby who's just living in their little cocooned environment.
Ding, ding, ding. Yeah, I don't. You got a 2-month-old. What are you doing? Laying them down in the cow pasture? Like, that's honest to goodness. They're not crawling, they're not walking. So offering the tetanus vaccine at this age, I just absolutely find to be silly. I will say that this is typically not one that you can't catch this from respiratory droplets from somebody else. And so looking at the CDC website for case count is, not typical, but I will tell you how rare tetanus is. And so currently in the United States this year, there's been 5 cases. And that's for everyone. That's not just under age 5. That's everybody in the United States is 5 cases. Now, this is one that parents are very nervous about. This is also a vaccine that you can get without pertussis. So you can get the TD vaccine. So keep that in mind, that after 3 doses, just like diphtheria, after 3 doses of the DTaP vaccine, you are fully protected from tetanus, at least for 10 to 15 years. So, except if you want to get quote unquote protected from pertussis, you need to get all 5 doses. So that's why there's 5 doses in the DTaP series. It's specifically because of the pertussis portion of the vaccine. And then, I think that we could probably have like an entire tetanus podcast one day. But I think that's about all I've got to say for tetanus if you're assessing risk. We just told you that it's typically, it's not typical of a rusty nail. But if you have a puncture wound that does not bleed, you for sure want to get to the hospital to get that, or the doctor to get that assessed, or urgent care, wherever you go. And douse with hydrogen peroxide while you're on your way to the clinic. And I think we still have plenty more. My goodness, Dr. Lydia, we've got lots of diseases. Let's chat pertussis.
Yeah, let's dive into pertussis, because this is one that infants can get, and
yes,
it's most dangerous for infants. And they also are vaccinating pregnant mothers, and you had a really interesting discussion about this in the VIP group. But yeah, so tell us about pertussis and how you manage that in your pregnant populations and or in your little babies.
Yeah, we'll talk about little babies. I think we'll do an entire Tdap and pregnancy podcast.
Okay.
I think that requires a lot, I think. But for littles, we're double the current case count. So this year here in the United States, as of this year, this time last year, we are at, here in end of April 2025, 9,000 cases of pertussis.
Otherwise known as whooping cough.
Yes, whooping cough. Last year, this time, we had 4,600 cases. And I just find it interesting that not a single news outlet has picked this up, and for good reason. It's because these diseases are cyclical. Again, they come and go year after year. There are always going to be different case counts, not because kiddos or parents are choosing not to vaccinate. It's just that's just the way it is. And so currently here in the United States this week, there's 175 cases. Good old Ohio, you got 23 cases right now. You've got 13 cases in Nebraska, 27 cases in Florida, 13 in Alabama, 21 in Arizona. Let's see, 10 in California, 14 in Oregon. Typically, when you see a couple cases, you're going to see a lot more. So pertussis spreads pretty quickly. Now, the question I get regularly is, why 5 doses? Why 5 doses of pertussis? Well, the pertussis portion of the vaccine really stinks. So back 20 years ago, we used to have the DPT vaccine, and that was the whole cell pertussis vaccine, and it worked really, really well. It worked too well. The side effects were so terrible that they pulled the vaccine from market, and they redeveloped the vaccine to an acellular pertussis, and it just doesn't work well. And so you fully vaccinate your child, and you reduce their risk after 5 doses 80 to 85%. Now, within just a few years, that wanes to 30 something percent. I think it's 34 or 37%. And now you need the age 11 Tdap dose, because the pertussis portion just does not work that well. So although you do opt for 5 doses for your child, that does not necessarily confer protection. It may in the very short term, but if you just do a quick Google search of pertussis efficacy, you are going to find it just doesn't work well. Does that mean that I say you don't get it? No, that's not what I mean. That you don't get the vaccine? That's not what I mean. I'm just giving you the current risk for some of these places that is actually kind of high. So if you were hunkered down in Cave Creek and you weren't putting your child in daycare, can you delay this vaccine? Yeah. So diphtheria and tetanus, obviously your 2-month-old or your 4-month-old is not going to need. They just need that pertussis portion. And so if you're not going anywhere, you can delay it. But if you do plan to travel, if you do have a lot of family around, it might be in your best interest to start the series this year, especially because we've now already doubled the case count and we haven't even gotten into summer yet. Then 2024. So that is the one disease that I would tell parents as of right now, so far, since of the list that we've talked about, Lydia, that's the one that I would say, well, are you currently breastfeeding? Because you are passing antibody protection to your child. You are delivering to your child your immune system through breast milk. And that is the absolute best protection for any of these diseases is breastfeeding. Are you breastfeeding? Was your child born vaginally or C-section? If they were born C-section, they just may not have gotten that Th2 switch as fast. It's the part of the immune system, Th1 and Th2 balance. And so some of these other risk factors I think are important in assessing whether or not you get that pertussis vaccine, not just looking at the current risk, because the current risk is quite high. If you live in North Dakota, there's no cases, not a big deal. If you're living in one of these states where we see some outbreaks, that is one that you want to think about.
It's also highly contagious, isn't it?
Highly, highly contagious. And this is when I would also start talking to parents. The discussion would begin, all right, you think that this is a good idea to vaccinate because you do see, case counts going up. All right, now let's talk about the risk of the vaccine. So the risk of disease, if it's high enough, let's lead you into the discussion. Let's talk about the risk of the vaccine. And then we would decide, when do you want to get vaccinated? How many doses do we do? Do we get tighter testing after doses? There's more to the story. Does that make sense?
Yes, it absolutely does. I want people to know that, we're focusing on the disease states in this episode, but we could have a whole other conversation, we probably will, about the vaccines, their components, and sort of to balance out the conversation.
Yes, absolutely.
Is this one where you'd recommend, if you're going to do it, you do all 5 doses to try to get up to that 80-85%?
It depends how old the child is at the time they start dosing, and it depends whether mom got Tdap in pregnancy.
Right. Okay.
Yeah, because I'll just quickly say it, maternal blunting is a real problem with this vaccine for the primary series for infants. So if mama got vaccinated, if mama got vaccinated in the third trimester of pregnancy, she might be helping to support her kiddo in the first 2 months of life
Mm-hmm.
with protection,
Mm-hmm.
but she is reducing the effectiveness of the primary DTaP series for her child moving forward. So now the child is more likely to catch pertussis even after having the 5-dose series, only because the child's not going to get as much protection from that 5-dose series because mom's maternal antibodies to pertussis are now messing with the vaccines that the child is receiving in that first year.
Wow, that was such a big wake-up call.
Did I explain that very well?
Yes, I think you did. So the fact that the mother is being vaccinated reduces the effectiveness of future vaccines for the infant and child.
Yes, even up through toddlerhood. So when you go to get that 12 to 15 month DTaP, they have done research on the toddlers, and even in toddlerhood, their titer efficacy is still lower.
Wow.
2 mothers who received the Tdap in pregnancy.
So interesting.
It's like, well, damned if you do and damned if you don't. It's like so do I get the Tdap in pregnancy because those first 2 months of life are so vulnerable for the kid? But if I get the Tdap in pregnancy, it means that their primary DTaP series is not going to be as effective. And the primary DTaP series for pertussis is not very effective to begin with.
Something to be said for really cocooning your baby in those first couple months, being pretty mindful about who comes over to visit, who's kissing up your baby, things like that.
It's laying in. We don't do it anymore. Unfortunately, here in the United States, we're rushed back to work.
Yeah.
Kiddo goes in daycare. We don't get much time off. It's not healthy. It's not healthy for families the way things are set up right now. And it's not just in the United States. So that's a bummer. All right. So that was pertussis. Now that, we're like in a bummed mood, let's pick it up a bit and talk about measles.
So fun. Love measles. Such a hot topic. And we're going to basically get into the MMR viruses, etc. And this is where a lot of our parents are concerned. We had a couple parents in a group that are like, my child's unvaccinated, but we're going to Disney World. We're going to be traveling this summer. What do I do? So learning more about what measles is and the viral infection. So this used to be something that people would get similar to chickenpox, right? Like it was pretty common to get measles. But, we've had a couple, I don't know the exact numbers of deaths that have actually occurred. I think they were in Texas. And so that is scary for parents. And it doesn't happen often. Yeah. It's not the majority of cases, but, even one case is very, very frightening and tragic. And this is incredibly contagious. Measles, if you're around it and you're unvaccinated, it's very easy to get. This is another airborne droplets situation, and measles can linger in the air for up to 2 hours. So it's definitely contagious. It usually starts with that red blotchy rash. You'll have a fever, cough, runny nose, sort of similar viral symptoms, and then the rash will kick in. But let's discuss case counts and how worried do parents need to be about measles?
Yeah, so here's the thing about measles, and a lot of people say, well, it's just a rash and a fever, but it's not. It's a respiratory disease, and so it is a cough, and typically secondary infections like pneumonia is the biggest problem to measles. And the one case of the kiddo who passed away, they passed away to a secondary infection of pneumonia. Now, the wrong antibiotic was given. I do believe it was a mycoplasma pneumonia, which is not typically the case with secondary infection to measles. And so the wrong antibiotic was prescribed. That's hearsay, just FYI. I know that there was a news outlet who picked up an interview with the parents. I watched the interview with the mom.
Yeah.
And the medical records were shared with this news outlet. And so that's just what I saw with that. Now, whether or not that's all true or not, that's just all for me to say that pneumonia is a big problem with measles. So it's not just a rash and a fever. And little ones who contract pneumonia, that is very, very scary and can be quite severe. So that is measles. It's not just a rash and a fever. Okay. Now, current case count for measles, I believe this is indigenous, correct? There's two ways to see it in CDC stacks. It's indigenous and coming into America. And so currently this week, there's 42 cases in the United States. And so far this year, there have been 560. According to CDC stacks, the number is actually higher right now, I believe, in Texas and New Mexico, if you combine them. But right now, what the CDC is reporting as, in fact, cases, so 560. Now, last year, around this time, there was 107. And in 2019, there were several thousand cases. It was like 2,000 cases of measles, I think, that year. So it does go up and down. I just feel like the media has really put a spun on measles this year. And it does. It grabs diseases. The news does, and likes to hang on and talk about them, talk them to crazy. So do you or do you not get the MMR? Well, you can't get it until after your kid's age 1 anyway. And that's the tricky part. Same with chickenpox, is that you can't actually vaccinate your kid in young infancy. You can get the MMR vaccine at age 6 months. And that is, if you are in an area where there's a current outbreak and it makes you very nervous, you can start as young as 6 months old, but it will not count toward the primary series. So your child will still need 2 more doses. So if you lived in a mandated state, to go to school, your child would still need those 2 doses after age 1 and then again after age 4. So I think that's about all I have to say for measles with regards to current risk. We all know the current risk. We're being bombarded with it in the news. So one other part of the MMR vaccine, we've got measles, now we have mumps. So do you want to speak to that?
Yeah, another viral illness that causes swelling of the salivary gland, so hence the name mumps, like you'll get the swollen cheeks. Fever, headache, fatigue. Most kids will recover with few issues, but this is one that can cause the meningitis, encephalitis, so neurological infections. And you can have inflammation of the ovaries and testes in older individuals that happen to come down with mumps, and that can cause, fertility issues, etc. So it's spread through respiratory droplets as well, and it's kind of common in areas where people are congregating together. We would say like colleges and schools and churches and things of that nature.
There was I'll just say it. There was a Navy ship out at sea several years ago, and so many of the members out at sea, so many of the sailors out at sea contracted mumps, even though they're fully vaccinated. They quarantined out there for a long time. I'm going to say it was over 4 weeks. So that leads me into saying that typically after 1 dose of the MMR vaccine, you have protection to measles and rubella. Now, because the mumps portion of the vaccine really stinks, you need at least 2 doses of the MMR vaccine to get mumps protection. And even after that, it titers wane pretty quickly to mumps. So just as an FYI, that when parents who live in a mandated state, they want to get a titer test for their kids for MMR to see if they only need 1 dose, I more oftentimes than not will see on the titer results that mumps failed. And so you'll need that 2nd dose in a mandated state. But if you are only doing the MMR for measles protection, you can typically get away with just doing 1 dose. Depends on the age of the kid, really. If they do it after age 4, titer efficacy is quite high if you do that 1st dose. And so you can run a titer test after that initial MMR and see if kiddo has enough titers to measles. But the reason why you need 2 MMRs in a series is typically because of this mumps. And the vaccine's not very effective, and you need reinoculated with the MMR within 10 to 15 years to continue having that mumps protection. Some people carry it better. Some people have mumps protection for much longer, but that would be why a second dose of MMR is needed in a mandated state is because of that mumps portion.
And can people just go and ask their doctor for titer tests? Is this just something that they could request from their pediatrician? How does that conversation usually go?
Absolutely. You know what I find fascinating, Dr. Lydia, is that veterinarians are doing it all the time for pets now. You take your pet in and say, hey, I want a titer test for their vaccines to see if we need to get their next round of vaccines or not. And veterinarians do it all the time. But a pediatrician will, it depends who your doctor is. You can ask, I'd like a titer test. Oh, insurance won't cover it. All right, well, then I'll pay out of pocket. Because I do know that if you go to LabCorp or you go to SnoreQuest or Quest Diagnostics and you just order the test out of pocket, it's relatively inexpensive. It's like under $100. So you can ask for a titer test. There's two types, qualitative and quantitative. Qualitative is, hey, you're immune or not. And quantitative gives you an actual number. So it just depends how your doctor wants to read that, because there's usually a reference range if it's a number to know if you have immunity or not. And I like to run that just because I like to know where you are with your immunity. And then there's also a qualitative where it's just, all right, do you have immunity or don't you? And that's called a qualitative. But yeah, you can ask your doctor, and I'll plug them. I'm not affiliated with them whatsoever, but schooltiters.com. I've mentioned them on many occasions. I have no idea who runs the outfit. I don't know who they are, but you can certainly order titer tests from there too. And you can, I think they send you a requisition and you go to Quest, I think it's Quest, and get your blood drawn and you've got your titers. So if your doctor won't do it, there is a way. And integrative physicians, you can typically find doctors who will do it. Maybe just not your own, which is really sad.
That's good information, though, so parents have options.
Yeah. Okay. So the last one, because podcast is going long. I hope y'all have been able to sit still through this.
Well, we'll timestamp as well. So if there's certain diseases
perfect.
people are interested, we can timestamp it on YouTube.
It's so tech.
Yeah, we're great. Trying our best over here, learning new things. Rubella, so the R in MMR, which is typically quite mild in children, I've come to understand. But it seems like it's mainly about not passing it on to adults who could have, or pregnant women in particular, pregnant people who can have really serious birth issues, birth defects, etc., if they become infected with rubella. But it seems like most kids, they'll have a little pink rash, but they'll be able to get over the symptoms. Again, respiratory droplets and quite contagious.
So it's women in their first trimester of pregnancy is who we want to look out for rubella. Rubella is not here in the United States, but it is overseas. So it's still everywhere, just not necessarily here. And I recommend to parents, if they have a daughter and they choose not to vaccinate the MMR, that when they go off to college, you have a conversation with them and let them know, here's the risk factors if you choose not to vaccinate with the MMR. One of them is measles. It's really painful in adulthood. And the other one is rubella. So if you have a daughter and you may get pregnant one day in the future, again, rubella is not around here in the United States. It is in other countries. So I don't know how you raised your kids and if they want to go down to Nicaragua for a while, or not to say that it's endemic to Nicaragua, but I'm just making up an example. Kids like to travel when they get out of high school. So just sit down and have that informed consent conversation. Hey, look, kiddo, do you want to go get the MMR vaccine? Here's the reasons why. And leave it at that.
Really good. This is really helpful.
Oh my gosh. Yes. I guess I could have given you it's zero cases of rubella here in the United States as of April 2025. We don't have any. And I think you also have here that it's super rare in the US, less than 10 cases a year. It's typically even less than that, just in case you were wondering what the current risk is of rubella in the United States.
This is so helpful. So parents really need to be thinking about case counts, travel, exposure risks, Like if you had to high level it, what would you say parents should look out for?
High level, the first thing, if you're thinking about vaccinating and you don't live in a mandated state and you get to pick and choose, what's the current risk?
Right.
And that's it. What is the current risk? What is the current risk of exposure for your child?
Yeah.
That is how you start the vaccine conversation with a parent as a physician for informed consent and medical freedom. Let's talk about the risk. Now, are all of the cases in the United States reported to the CDC? No, they're not. But it's a really great starting point, okay? So I know there's going to be a lot of those out there who want to argue with me on, well, that's not a really great way to decide whether a kid should get vaccinated or not. But it's a great way to start the conversation. And then again, like I said, as an example with our pertussis cases, the next step is, all right, we've assessed current risk. It makes you nervous, whether it does or doesn't.
Yeah.
But if it does make you nervous, all right, now let's sit down and talk about what vaccine is used for this disease. What are the FDA package insert post-marketing surveillance? What was the clinical trials for this vaccine? What are the, known side effects, whether they are not so bad all the way to severe? So side effects to, injection site redness all the way to encephalitis. So we talk about that and parents get curious and I get curious with them. And that is the next step is, if any of these case counts stress you out to the point where you do want to vaccinate, let's go to the next step. And let's talk about the vaccines. And also let's talk about your current own risk factors. Do you have a child in the home who's older and in school?
Sure.
Who may bring something home? Do you plan to travel? Do you have immunocompromised in the home? Child born vaginally? Are you breastfeeding? Those are all important in determining the schedule for your child. And so the schedule is not a one size fits all, like the CDC states and several states mandate. We're all different. All of our genetics are different. I could just talk all day, Dr. Lydia.
This is very informative. And I want to just remind parents, we were getting our numbers from the stacks.cdc.gov website, which is, there's probably lots of places to get numbers from, but if you're going to be communicating with your doctor, that would probably be the most credible source, I would say.
That's a great place to start.
It's a good place to start for sure. There's also local public health agencies. You can look into that. I noticed CDC will list some, particularly for measles. They had, Texas and New Mexico, their local public health agencies. But just as much as Dr. Mayer would start the conversation there with parents, if you're going to your doctor, you can also start the conversation there with your doctor as a way to open up the door to talking about vaccine flexibility and alternate schedules, or if you're just declining.
Absolutely. And like I said, there's nothing that tickles a pediatrician more than an informed parent. So, and I don't know, it might tick them off actually, but I love the more informed we parents are, the more we can take a stronghold on what's best for our family and what's best for our kids. And it's empowering. It's absolutely empowering to be able to walk into your pediatrician's office and say, this is what I want to do and this is why. And here's the scientific rationale for all of it. And then let them answer you and, see what they have to say. So I loved this podcast. This was a lot. This was very long-winded. Dr. Lydia, I'm so glad that I had you on today so that you can sit here through it with me and we can just kind of,
I learned so much.
Chat about it.
This is such good information. And thank you to all our parents.
Absolutely. All right. Well, we have another podcast coming up. So please stay tuned and have an awesome day.
Thanks, everyone.
Bye.
Bye.
I have so much more to talk about. So if you'd like to continue listening to this conversation, please join my VIP membership community. After signing up, you'll have access to my full-length episodes, my very lengthy library of parent-focused resources, including my treatment protocols, access to my parent support group, and exclusive product discounts. Join my community at drgreenmomvip.com. Thank you for listening, and I'll see you next time.